Good evening, everyone, and welcome to the very first webinar of a new series we're launching called CPARF in Conversation. We'll feature researchers, innovators, and important voices in the cerebral palsy community. I'm Jocelyn Cohen, and I'm the Vice President of Education with Cerebral Palsy Alliance Research Foundation, or CPARF for short. This event is closed caption enabled, and I've turned on transcription. It's also being recorded, and we'll post it on our YouTube channel soon. For additional accessibility, I'll share a visual description of myself. I'm a white woman with dark brown shoulder-length hair that's down and brown eyes. I'm wearing large teal glasses and a gray and white turtleneck sweater. There's a CPARF-related background behind me that has white and different hues of green. And sometimes I might look like my eyes are looking away from the screen or that they're rolling, but that's part of my cerebral palsy. In case this is your first online event with us, I'd like to tell you a bit about what CPARF does. Despite being the world's most common lifelong physical disability and affecting 18 million people worldwide, cerebral palsy is one of the most underfunded conditions. That's why CPARF funds research and technology that will positively change what it's like to live with cerebral palsy. On the innovation front, we run Remarkable US, the US-based disability tech startup accelerator that's part of the global Remarkable Accelerator program. And through seed funding, mentorships, deep dives, and support, we help startups bring affordable, life-changing technology one step closer to the people with disabilities who need it. Because the world isn't built for disabled people, but thankfully, there are companies that place disability at the forefront, and Remarkable US is working with them. They're built to fill in gaps, meet crucial needs, and make accessibility accessible. On the scientific side, we're currently funding an array of projects that address cerebral palsy at all ages and stages of life. CPARF-funded research projects focus on chronic pain, technology, regenerative medicine, genomics, adulthood, and early detection and early intervention. The discoveries that researchers make today will make a difference for millions of people for generations to come. And tonight's guest, Dr. Colleen Peyton of Northwestern University, intently studies ways that we can help the youngest children get the best possible start through early diagnosis and early interventions. Colleen earned her doctorate of physical therapy from the NGH Institute of Health Professions in Boston and her BS from Pennsylvania State University. She has earned numerous awards, including a past Outstanding Pediatric Clinician Award from the American Physical Therapy Association. And I'm excited to chat with her tonight. Welcome, Colleen.
Thank you so much for having me.
We are so glad to have you. So to start things off, can you tell us a bit more about yourself and your professional background?
Sure, yeah. So I do research as like my full-time job now, and I also teach physical therapy students at Northwestern, but my background is really as a clinician. I started as a practicing physical therapist and spent 14 years in the clinic at University of Chicago here in Chicago. So I've been in Chicago my entire career. And I started working with young children from the beginning. And that's really, that experience is what sort of drove me into research and clinical questions.
That makes sense. I can understand why working with little ones and seeing what they're encountering might drive you to say, oh, let me see how I can help in another way on top of what I'm already doing.
Yeah.
So that sort of leads into the next question. What specifically motivated you to focus on pediatrics and then specifically early CP diagnosis and early intervention?
Yeah. I always have liked working with children, so I knew I wanted to do pediatrics. And then when I was a PT, I worked in the neonatal intensive care unit or NICU. And I like to do a little bit of everything still. I also worked in the outpatient clinic afterwards. So we would see babies in the NICU who were born early or who were born and had some issues that they needed intensive care for, some sort of brain injuries at birth, or maybe they were born early. And then we would see them in outpatient clinic, NICU graduates, we would call them. And this really fun to work with this population and watch them grow and change so much over a short period of time. But one thing that I realized was I was not sure, because a lot of babies that pass through the NICU have different types of medical complexity and brain injury. And
Sure.
then when they would come back, in outpatient clinic, I realized, I wasn't really good at understanding which kids, when they left the NICU or even when they came back and I would follow them over time, were most likely to develop cerebral palsy. And through this sort of question I had about, like, especially in the area that I worked, we didn't have enough services to go around. So one thing I was really determined to answer was, how do we find those kids that sort of need these scarce resources the most, and thinking about kids that maybe would be likely to develop cerebral palsy, or like, how can we figure out which ones of these kids would benefit most from triage services? And then I found this general movement assessment looking through the literature. And at that time, there was no one really doing this in the United States. And what the general movement assessment is it's a way to watch the way that babies move naturally. And the way that they move tells you a lot about their brain. And there's some things that tell you with a high degree of accuracy just by watching them, whether or not they might have cerebral palsy. And I thought, oh my gosh, I have been watching babies my whole career and I miss this. Like, it just really like turned my world upside down. You mean I can just look at them? Like, I've already been looking at them. What am
Yeah.
I missing here? And it just made me sort of say, like, what else am I missing? I kind of want to study this and understand, like, what else don't I know? Like, what else can I learn? Because it seems so huge. And so then I learned the technique myself. And then it really expanded my world. I wanted to test it. I wanted to share the knowledge with other people. And that sort of launched me into research and teaching, because I thought this was so amazing that I had been here. They had been right under my nose. There was no
Yeah.
special equipment required. It was just being able to recognize that the way that they moved at certain ages were reflecting what was going on in their brain, and that some of the movements were more likely to indicate that they did or did not have cerebral palsy. So that's sort of what launched me into this direction. And I've been at Northwestern for 6 years now, and I've been doing research for about 10 years.
That's fantastic. And it just goes to show that small things really are big things sometimes. If you're watching for a very specific movement that indicates something huge, like just looking for the small details makes a gigantic difference. And we'll get a little bit more into the general movements assessment that you mentioned a little bit later on tonight. Um, CPARF, we're currently funding several of your projects, and each research project focuses on fidgety movements as a diagnostic point. So can you further explain what fidgety movements are and why they're so crucial to a CP diagnosis?
Yeah, so fidgety movements are an age-specific movement pattern. So just to go back before fidgety movements just a little bit, the very first movements occur in utero when we're only 3 centimeters big, as little fetuses, like the size of a kidney bean. And these movements are generated from our brain, and it's sort of the first pinging of our nervous system. That's this electrical activity that lets us move around as fetuses. And this movement helps to form the looping that's necessary for sort of all the movements that we make now on that outside extra utero movement. And actually, when we're born, we still kind of move and are acting like the fetus. It's just that we've been born, but we take still longer to develop. So you can kind of notice when babies are first born, and what they do is, they can kind of move around a lot and they're moving a ton, but their movement becomes more and more purposeful and goal directed over time. And there's these like age specific time frames in which the brain is organizing itself, and then the movement is reflecting what's going on in the brain. So around 2 to 3 months of age, babies kind of transition from moving around like they did when they were the kidney bean, like a fetus, to more of these small movements in all directions of the joints, of the wrist, of the neck, of the shoulder. If you can't see me, I'm moving around in small movements, also in the hips and the ankles. So any joint that can kind of move in multiple directions, the babies just start to do this when they're awake. And sometimes it's a part of other things that they're doing, like reaching for their head or their mouth or their hands together. And they're doing this a lot when they're awake. And my colleagues in Europe figured out, because the babies are constantly moving when they're awake and active, that this particular fidgety movement pattern was related to CP. So babies who don't show these small movements in all directions on both sides of the body are more likely to have CP. So
Okay.
whatever in the circuitry of the brain that produces these movements is also related to the way that kids and adults move who don't have CP. They don't do this in this little window of time. And so that movement pattern allows us to sort of know with if we see them or if we see them on both sides of the body, that this baby's unlikely to develop CP, and that babies who are moving a lot, which all babies do, which is great, but they don't move like fidgety, they are more likely to develop CP or maybe have CP.
I'm wondering if a piece of that has to do with already a muscle tone issue. Do we know the reason behind it yet? Like why there aren't the fidgety movements? Is it all the signals from the brain? Is it tone? Is it spasticity? Is it some combination of those things?
So really interestingly, babies with CP don't really have spasticity yet. Like little babies this age who are 3 months and younger, most of them don't. So that's something also that develops over time, which is interesting too. So it's probably whatever in the brain produces these tiny movements. It's now I'm in speculative territory, but it's probably
Sure.
related to this sort of the relationship between the higher brain, the brainstem, the basal ganglia, and the spinal cord. So something in there, all those pieces are making fidgety movements. And so if there's a sort of a lesion somewhere along there, then these tiny movements are produced. But other movements are produced. Interestingly, the babies who have CP are also moving, which is fantastic. They
Right.
just don't move like this for some reason. And I kind of think to myself, it's so amazing that we, meaning the royal we, other people
Yes.
before me, figured out that this particular movement was related to not having CP or having CP. But where in the brain is this being produced? We can only sort of guess by what's going on in the brain at that time, and what precedes it. So right after sort of these fidgety movements in development, we have reaching and grasping and sort of more intentional behavior. So perhaps the role of this is sort of a fine tuning of this motor circuitry loop, which can also occur in lots of wonderful ways in people who have a CP just differently, and they don't somehow produce these on both sides of the body. So even in children with unilateral CP, they
Sure.
may produce it on one side of the body and not the other.
That was going to be another question. Like
Yeah.
if you're observing a baby and you see that they don't have the fidgety movements on one side, but they do on the other, you can say that baby is likely to have hemiplegic or unilateral CP.
Yeah, or at least it cues us to say that's a possibility and we should get an MRI or other
Sure.
additional testing to confirm that that could be the case. And amazingly, sometimes
Oh, your sound dropped. There, you're not muted, but I lost your sound somehow.
can you hear me now?
Yes. Yes.
Okay.
The gremlins, they came to the webinar too.
So sorry.
No, that's okay.
Anyways, I'm trying to, so it's sort of like how much of this movement can the brain produce? Because kids with CP, sometimes they produce it, but just a tiny bit. So
Okay.
we don't honestly know why all the way. We can only kind of guess, but we do know that it does help us clinically to sort of as a sign that can help us to make the earlier diagnosis or at least cue us to get additional testing to confirm that.
And that's really crucial, getting that early start. So your first CPAR-funded study with us, because you're like I said, you're doing multiple projects with us, which is so amazing. And your first CPAR-funded study with us is an international collaboration, and you mentioned a little bit about that earlier too. It's between the U.S., Australia, and Italy to study the timing of these movements. And can you share, beyond what you've already said, why that's important and why the international collaboration is so important too?
Yeah, so what's so amazing about this is that all babies are doing the same movements all around the world. But it's nice to have an international team to sort of verify that different parts of the world, that babies are kind of moving in the similar sort of space and time, and that we can sort of generalize this to 3 different continents, and that also that this sort of method of maybe I can talk a little bit about what we're doing. So actually,
Yeah.
we came up with this idea. So myself and my Australian colleagues who are also involved in the Cerebral Palsy Alliance, we're all also tutors of this method. And so right before, it was in 2019, so before COVID,
Yeah.
my colleague Alicia Spittle had an app, a phone app called Baby Moves, that we were working on a project together. And the parents actually collect the data for us. So they
Oh,
take a video of their babies, and there's a cute little baby outline on this app. And then it uploads the data into a secure server called RedCap that we use for research. And so we were meeting at a conference, and I said, do you ever wonder, like, because when we originally learned, again, the royal we, the
yeah.
group before me, about these fidgety movements, it wasn't always tested in babies that we would test for now. So babies who come through the NICU follow-up clinics can have also something called bronchopulmonary dysplasia, where they require oxygen for a longer period of time, or
Mhm.
congenital heart disease, or other congenital anomalies that require surgery, or maybe the baby has a longer period of time where their nervous system may be suppressed due to the necessary surgeries that they need to take care of their congenital anomalies. And we were sort of saying to each other, have you ever noticed that these kids, maybe they don't fidget till later than we would expect? But that had never really been tested in this original cohort that was the foundational cohort. And so Alicia Spittle, who came up with the Baby Moves app and is a colleague in Melbourne, Australia, said, our app, we just got it to be able to take more videos in a row. So if we wanted to test that, we could sort of sequentially ask the parents to take videos over time to see in maybe these groups of kids, do these movements come in later for some groups of kids, as we suspected from our clinical findings, both as clinicians and as researchers.
Right.
And that was right before COVID. So
Perfect timing,
it
actually.
was perfect timing, because this is a way that we could internationally collaborate, having parents collect movement data, because all we need is to have them film their infants moving, which they're doing all the time when they're awake and calm.
Yes.
And we could take a video of them every few weeks, six time points in development to test and see, in some babies, does this movement come in later if they have certain conditions or not? And with an international cohort, it's great because we get babies from all over the world, but more babies because each site can collect babies. So it's also, we're all interested in it. We're all, we all have been or are clinicians.
Yeah.
And we all teach clinicians who bring these questions to us that they also want to know. So we have a little inside scoop on, what are clinicians interested in and what are the problems that they face in the clinic about how to make these decisions. So we get this information from them when we teach these courses. And so it's great. So we can partner with families and sort of partner with clinicians to do this work.
Cover both sides of it. And actually, also because you said that you're also a physical therapy professor, this is now importantly making its way to students who are going to know it immediately, where you had to really figure it out in your practice and then go and pursue this research. So it all kind of ultimately lifts the generations that are to come, which is fantastic.
Yeah. And everybody loves an app. That's the new
Everybody
student.
does love an app. It is true. If you don't
Yeah.
have an app, you're behind, to say the
But
least.
yeah.
And so you've shared how it was really helpful that this was an international collaboration, especially in a time of remoteness and people not being able to go like in person to clinicians. What can you share about how the study overall has gone? Because I think the work that you're doing that we're funding is sort of each is layered on something that came before it. So can you share a bit about that and how things have gone so far, what your findings are?
Yeah. So the first study where we started with the app, we're still actually collecting some data. So we don't have like the entire results, but what we kind of learned, I think, that can be immediately translatable is that even if you're not doing research, that parents collecting data has been a real success. Most parents are able to do this successfully. Also, we find that, for instance, when you bring a baby into a clinic, especially a baby that is a NICU graduate or something like that, you might not know what you're going to get. They might be upset. They might not be familiar with their surroundings. Maybe they've missed a nap time. Who knows, right? But when the parents can record the baby in the home, they can choose the best time for the baby, and the baby's already comfortable in their own environment. So one thing that I think we've learned from this is that this is a really good way for us to get information. So for an immediately translatable finding to clinicians is if they can't get the family in for a visit, that this is a great option for them, because they can do it at a time that's convenient to them. Most parents are already taking videos of their newborn babies on their phones, so it's not a foreign concept to them. The
Right.
babies are moving when they're awake and happy, and the parents can kind of capture the time that works best for the parent and for the baby. So one thing that I've learned is this is really a viable way to get information in a way that's convenient for the family, and actually is sometimes a better performance for the infant.
Mhm.
And that parents can be easily coached, because we do have a few rules, like they're not supposed to use a pacifier, and they're not supposed to wear a lot of clothing and on a flat surface. But most parents, if you tell them that, they are fine with that, or if they aren't, then just a little reminder, no problem. So
Yeah, I mean, because I would think if you have a pacifier, then that's gonna potentially encourage like different movements that aren't going to let you look at baby as closely. Or if they have clothes, they might reach for a snap or something and do something that's gonna distract your eye when you're observing them on the app. Is that the reasoning behind it, or is it something else?
yeah, so well, kind of. The pacifier allows them to suck, and then they go into the sucking posture where they flex their arms and extend their legs, and then they don't do as much moving around in the ways that we want to see. So that can suppress this movement, this fidgety movement. So that's probably with the pacifier. And then, of course, if you've seen a baby crying or even yawning or something that involves the whole body, like when they cry, they involve their whole body, and then they're not moving in these little ways. So it's really like what we call state dependent, meaning the baby has to be calm and alert, which is sometimes hard in a clinical setting because it's
Yes.
an environment for
In
them.
addition to the factors that you stated, temperature regulation isn't so great among NICU graduates.
Yeah.
And I think that usually clinics would probably be a little colder. So that's
Could
gonna
be.
be another reason maybe that a baby
Yeah.
would react in those situations.
Yeah. Yeah, I've
So
even had parents send me videos from a beach once. So it's fun to see their home environments. You see the pets running through the frames and the siblings coming up. So, it's a little taste of
and
what
then
they're
you're
like.
like, the baby went on vacation and the baby's first beach vacation. I
Yeah,
love it. I love it doing
yeah,
multiple things at once.
exactly, exactly.
So, you've had a lot of good findings so far, and how will these findings help children who are at risk for CP beyond what you've shared already? Because I know you've shared a lot.
Yeah, yeah. The next sort of study that is layered on top of this is, so the first idea is to see what times when the parents collect the data. And now in the second phase of our study, we're looking at what are the 2-year outcomes. So what is their motor, cognitive, and language outcomes at age 2? Also, do they have CP or not? And also, two other things that I'm really excited about using is that something called the infant toddler quality of life. So that's obviously filled out by the parents, because a 2-year-old isn't really ready to fill out a quality of life survey yet. Um, and also something called the child behavior checklist. So the child behavior checklist kind of tells us about behavioral issues that are maybe down the road. So what's interesting about all of this is that we can connect then the way that they moved early in life to what's going on with them at age 2. And so that can help us to confirm whether or not they have CP and how the movement is related to that. So in some cases, let's say your baby was born early and had a condition called bronchopulmonary dysplasia, which means that they were born early and they continued to require the use of supplemental oxygen for quite a while after they were supposed to be due originally, the original due date. That these babies, because they require oxygen a little bit longer, are known when we look at their brain volumes as a group to be somewhat like it takes their nervous system a while longer to myelinate, to form the connections between the brain.
Okay.
That maybe their fidgety movements, that they have them, but maybe they come in later in development. So by 2 years of age, we can see, did they have CP or not? And if they didn't have CP, did they have fidgety movements later? And so then what we can do going backwards in time is to say, maybe these kids who didn't have fidgety, maybe they weren't going to have CP, maybe they just needed to be tested at a different time. Or
Mhm.
maybe this is the better time to test all kids because some of these conditions that we really didn't know about originally, but passed through a NICU and should be screened for conditions like cerebral palsy, should be screened at a different time. And that will help families not to have to kind of keep coming for repeated visits.
Yeah,
So either way, whether or not the families receive a diagnosis of CP or not, we can optimize the clinic time to the best time to detect it, depending on maybe what has happened in their medical history.
right.
So it eliminates the need for sort of so like families who maybe aren't in that won't get a diagnosis of CP, maybe they don't have to send as many videos, or we don't have to put them on the radar that maybe it reduces the chance that we go forward with a testing that would say they might have cerebral palsy, like an MRI or something like that, perhaps would be the implications.
And the other piece to that, frankly, is a level of peace of mind, and just less stress potentially, for those parents when you're sort of waiting for something in the background. I mean, people know this whether or not they've had a premature child or a child with a disability or any kind of health issue. When you're waiting for test results or you're
Yeah,
told to wait a certain amount of time, you won't know for X amount of weeks or months. That puts you in a certain kind of mental state. So if you can allay those concerns, um, at an earlier point and say, you know what, it's because of the developmental delay is because of these other things, and it's just a delay they're actually going to catch up, as opposed to a developmental disability like CP is or one of the other disabilities.
exactly. And then also for those families that do get the diagnosis of CP, then we can maybe be more sure that this is probably, we've done it at this test point, this is it. And then we can sooner give those families supports that they need and want, and also give the kids the early intervention and support that they need.
Yes. And we were talking a little bit earlier, and I was fortunate to be diagnosed relatively early for my age. With CP, I was diagnosed at 8 months. And while it sounds really long right now in the context of the general movements assessment, because it seems like you can diagnose it so early. Is it 12 weeks and earlier? Or are you trying to get it to be even earlier in the study that you're doing? Or
Well, in this study, it's probably around 3 months would be like, and
okay,
then prompting if they haven't had an MRI, if we're in a place where we can have MRI, then then this 3 month time point is sort of the target area for right now. Yeah.
okay,
And
and
then if with additional testing. So just the movements alone are not enough to make the diagnosis, but some babies have already had the MRI, and this would be the second part, or maybe this movement part is the first part, and then the MRI is the second part.
okay. And do you know, like pre-general movements assessment existing, what the average age for a CP diagnosis was? I've heard so many different things. I've heard a year and a half, two, and I always felt super lucky that I was diagnosed early and got early intervention at 8 months old. But I don't know what the average is these days. 'Cause I hear a lot of different numbers. Do you know what that is off the top of your head?
Yeah. So the general movements assessment has been around, published since 1997.
Okay, so that's a
Um,
while.
but not everyone's used it because it takes about 17 to 21 years, but between the time something is published to get people to use it, or to implement it on a regular basis. And
Wow.
still, when I teach around places here, it varies by region. But in the US, a lot of clinics are still diagnosing kids at age 2. So I think age 2 was the gold standard for a long time. Even I was just reading an article today that was sort of recommending 2. This was published in the 90s.
Okay.
So it's old. But I think that was the old recommendation,
Okay.
or the old standard of care. But yeah, now we would say 8 months is still a bit for us who are working in this field, a
Right.
bit, but that's great for when, like, since if you were born before the 90s, and you don't have to say when, but
I
I
was
know
born before the 90s, yes.
8 months is pretty good at that time, since that at that time it was 2. But now I think we have the tools and the knowledge to have it as early as 3 months.
I mean, that's such a it's really great to see that in my lifetime, because that's that's such an advancement that people in my generation and forward did not have until relatively recently, I guess, because it takes so long for science to get adopted. Like you said, I didn't realize that it took 17 to 21 years. Um,
Yeah.
I hope that the length of time for adoption shortens, and that as you and others like you are doing research like this, that it, ripples out in exactly the way that we want it to, so that no matter where someone is, they can get the care that they need at the time that they need it.
Yeah.
It's a
Yeah.
real, everything kind of builds on itself. And we talked already about how the second project you're working on that we're funding is building on your first. How does the third project that we're funding connect with the others and then further advance the early detection and early intervention work?
Yeah, yeah. So the third part is actually we don't have to collect any additional data, luckily.
Okay.
We can use the original data set of these movements to do a detailed version of the scoring, which allows us then to compare with these 2-year outcomes. So some of the other things, so babies are, I was talking to one of my engineering colleagues who love to look at signals and things like that. It's like babies are producing a constant movement signal. So, like, if I am sitting around in my house and it's been a long day, or even let's be honest, during my workday, I could just sit still for a long time. But babies, they don't sit still, they're constantly moving. And that's whether or not they have CP or something else. So their brain is producing all these movements. There must be some purpose to them. And they generate a lot of different movement behaviors around this 3-month time period. So the same videos that the parents have collected for us with the smartphone app, we first looked in the grant 1 for fidgety general movements and how do we see them and at what time. Grant 2, we looked at 2-year outcomes. And grant 3, we're going back to the movement data and looking in fine details for all the other patterns that they're showing us. And then we can look at those behavioral outcome measures, the cognitive outcome measures, the language outcome measures for kids with and without CP, and maybe other conditions that we don't know yet. We're just discovering now. Maybe perhaps some kids whose data we're collecting, they may develop autism spectrum disorder or speech and language issues, or maybe some kids with CP also have, in addition to motor issues, they may need also help with speech or cognition. And so looking at these other movement behaviors aside from fidgety may also be able to help us precisely understand the link between these early movement behaviors and these outcomes later on. And so it can help for kids who are diagnosed with CP, and then other kids, these NICU graduates, as I say, who go on to have other, differences in their development that may show up on these 2-year outcome measures that maybe aren't related to fidgety, but other movements that the brain is producing.
Sure. That's really, it's so interesting to know you're basically, is it following the same exact people this entire time throughout all
Yes,
the studies? So it's
yes,
a real longitudinal study then,
yeah,
to see what's happening with these children. And I think that's especially fascinating to me, just as an adult with CP, also as someone working at an organization that funds CP research, when you're looking at the same people over a long time period. And I feel like the results that you're going to get from these layered studies are really going to help, again, in this positive way, for clinicians around the country and around the world, because this is an international study, give that great start to the babies, and give peace of mind and or information to the families right when they need it. What would you say at this point has surprised you about your findings, if anything?
yeah. I think one thing that has been a little bit surprising. So in the advent of Zoom, we got good at Zoom, and we use it to our research advantage. So we do a poll where our raters are blinded to the ages of the babies and their background history. So some of the babies were born full term who had actually didn't go through a NICU at all. Some of the babies were born early. Some of the babies were born at term, but they maybe had a stroke or another kind of brain injury, but we don't know any of the background. And so, as a group, and across country groups as well, we're pretty good at saying, yes, this is here, or no, this is here, not here. But I think what we're going to find, this is just without analyzing anything yet, because we
Yeah,
haven't finished it all the way, is when we get into like granular details about the fidgety movements itself. How big is it? Where is it located more often in the body? We have less agreement on that as a group. But what's really, I think, most important is it there or not, which we are in agreement about most of the time. The other thing that I has surprised me in a way is sometimes now we have enough kids where once they finish their trajectory, we can become unblinded to their history and sort of watch, especially if we were concerned about their trajectory.
mhm,
Um, that sometimes they start out bigger in general, like a category that we didn't realize before. Um, we teach that in our class, and then they actually over time become smaller in that way. So they what we would consider in their general movements normalizing. So they start out with really big, and then they go to smaller over time, which is really interesting. And we didn't expect that, I don't think. And we didn't know that because I don't think we've studied the fidgety movements over time before.
right,
Yeah, I think that, and I was thinking about like, why is that? And because I think traditionally before we had phone cameras on our phones, the kids would have to come in for these appointments,
right.
and that's a harder thing to study, right? So it was easier for researchers while they're in the hospital to film them because they're
Yeah,
residents in the nursery, captives.
I was about to say captive audience. Yeah,
Yeah, but it's harder to bring them in like that to the clinic all the time, but it's a lot easier for the families to film them, of course, and send us the videos. So I think what's been surprising to me is, we really haven't studied this that much, and the use of smartphones has really unlocked this and made it more feasible for us to study this. So I've been really surprised by how consistent the families have been in returning the videos, and we're very thankful to them, of course, for participating. And then some of these trajectories that we've seen have surprised me as well. Like I haven't seen that before, but I think the reason I haven't seen that is because I've never really watched
right.
sequential before. So it's been fascinating.
I mean, it's fascinating to me just hearing you talk about it. And I'm curious down the line about what causes someone to have those big movements and then, as you said, sort of normalize over time and the the questions that you're uncovering while you're doing these studies and like what that will lead to in the future is also really interesting to me.
Yeah, I
Um,
think the other exciting layer is, does
yeah,
that mean anything for their 2-year outcomes? So
right.
that's the next thing.
That's
So
the
that
next
will,
that's the
yeah,
next one in the queue that you're working on. So that's
yeah.
really exciting that that's already ready to go. So we have a few audience questions that came in, and I want to make sure I get to some of those. Someone asked if you can provide insight on the effectiveness of a consultative model of physical therapy treatment versus intensive PT, like hands-on therapy 2 to 3 times a week.
Yeah, I'm not exactly sure if hands-on means literal hands-on or if it just means like you're with the person.
Sure.
I think that there's some trials going on now that kind of that talk about whether or not what is like dosing, if that's the question that we're getting at, is if it's
Mm,
dosing,
I
how
think
much is needed. Yeah. And I'm not sure, and if it's hands-on, like hands-on to move the child, I think that what we do know now from a lot of the work from the Cerebral Palsy Alliance is that the child who initiates their own movement, that leads to better effect in learning behavior. So at this age now, they're able to initiate their own movement. So practicing those skills where the baby is initiating their own movements seems to help strengthen those connections in the brain, which are responsible for initiating their own movements. So I think if the question is, hands on or hands off, of course, babies are not sometimes able to hold themselves up and all that. So they need
yeah,
some level of support. But the dosing question about how much is needed is still being tested. I think
right.
it seems that the younger you are, perhaps the less dosing you need to be effective. So we can capitalize on the younger age of the brain to I kind of think of it like this, if you think about a baby in the first year of life when they're born, and now we know they're acting sort of like a fetus still, and then by the end of the first year of life, a lot of babies are able to point and pick up Cheerios and maybe stand up on their own or take steps on their own. So there's this huge period of time in the first year of life where they're developing their motor skills. It's the biggest growth of motor skills in brain development of all of life, really.
Yeah.
We don't ever go from, playing, moving, they're still moving, to standing, and in some cases walking. So it's sort of like, when I could go out and learn Portuguese, let's say now, but if I have a 2-year-old kid, which my kids are older now too, so they'd have to be taking remedial lessons with me, but they could, if they go to Portugal and I go to Portugal, they're going to learn the language a lot quicker than I am. We both can still learn, but they're going to pick it up and be like native speakers rather than me, who will still learn the language, but I need more practice and it's a little bit harder. And also people won't be able to they'll still hear my Chicago accent somehow in there. So the motor window of time for this is the first year or first 2 years of life is this critical window of time where if we can really target interventions during that time, we may be able to, like language, to get a little bit more optimization of those skills by intervening in the time when the brain is most sort of open to developing those changes.
The neuroplasticity.
Exactly.
A really good window. So someone who's live here today said, as an early intervention PT, how does your intervention look different for a baby with normal fidgety versus absent fidgety movements?
Yeah, I think that's a really good question. I think the fidgety has less to do with the intervention. It's about if they have CP or not. So kids who have absent fidgety are more likely to have probably CP. And so then we would want to do interventions that are CP specific interventions for the kids maybe who have absent fidgety and are also diagnosed with CP or have a high likelihood of developing CP. So I think that if they don't have fidgety movements, it's not like we're going to try to make them have fidgety movements, but instead we would encourage them to begin CP specific interventions depending on what their presentation is like.
Thank you for that. Someone also shared some helpful information in the chat about different an article on evidence-based early intervention for kids who have GMFCS levels 4 and 5 who aren't ambulatory. And if you're attending tonight and you don't know what GMFCS is, it's the gross motor function classification system, and there are 5 levels in cerebral palsy, and it's essentially based on how much assistance you need to move in different ways. And if you want to add more color to that characterization, feel free, but that's my easiest way to describe what a GMFCS is.
I think you did a great job.
So we had another question from Indonesia, basically asking about disseminating this research. They're asking general early intervention questions, but I know that as an organization, CPARF is committed to helping disseminate research, and that's additionally through our strategic partnership with the Cerebral Palsy Research Network. But if Colleen, you had some other ideas or thoughts to share about disseminating this research once it's done, please share that.
I think that the Cerebral Palsy Alliance, honestly, and I'm not just saying this, is one of the best disseminators of research. I think that the organization as a whole and the researchers that are in it are so wonderful about, putting out guidelines that are easy for clinicians to understand and understanding implementation science that clinicians need to have easy to follow sets of instructions with clear guidelines. And that's why they've published both the early detection guidelines in 2017 and then also the early intervention guidelines in 2021. So of course, if research articles aren't your thing, there's also, publication, there's also resources on the Cerebral Palsy Alliance website and handouts that can be provided to organizations as well that look at, what is the latest evidence and how to do that. And maybe also through some of the opportunities that you're talking about through sort of conversations like this and the podcasts that you're talking about with research dissemination.
Yeah.
I think the other thing is another reason for our international collaboration with the two sites in Australia and the site in Italy is because we all are training clinicians in this general movement space. So what we do in these classes is the classes are changing all the time. And it's not an ad for our classes, but just that we are disseminating the research as it comes out to the audiences that receive it. So if we learn more about what general movements are when they come in certain populations, we immediately turn that over and disseminate it to those audiences. So we are also providing information through conferences and courses and things like this, webinars and podcasts and internet sites. So the information is out there. Yeah, and we're trying to, because we know how important that is. We don't want to have people have to wait 17 to 21 years.
Right. That makes me that upsets me. Just in general, for CP research and any kind of research, honestly, we all have something to do, something we have to monitor in our health. We're human, so machines aren't perfect and they break down, and you have to get monitored for things. So to know that some of the state-of-the-art research that's happening now is making its way to where it needs to is a really great thing. Someone in the Q&A asked, can you give an example of CP-specific intervention during infancy?
Yeah. So for instance, let's use this example that sort of incorporates my research with early intervention research. If we see fidgety only on one side of the body, and that cues us to think maybe this child is having some asymmetry, or maybe this might be a case of unilateral CP. So that could be confirmed with the Hammersmith Infant Neurological Examination, or the HINE, and also the asymmetry score on that, plus the type of brain injury that the child may have. If they have, for instance, a one-sided unilateral CP, then we might want to do targeted interventions to target the paretic side and the use of that more. And there's two specific CP interventions. One is called constraint-induced movement therapy, where the baby, 3-month-old, wears like a little sock or a long onesie with a chip clip or something like that over the top, and they do focused training on reaching and using that extremity. The other information that's coming out now is that also something called bimanual training can be also equally effective. There's some trials coming out about that now, where the infant is encouraged to do focused play using both hands together. So if one hand isn't as active a participant, using toys that are bigger or games that incorporate the use of both hands would be targeted to, for instance, to that one extremity or the side of the body, which is having challenges in movement. So targeting to those body structures, for instance.
I hope that helps the person that asked that question. As someone with spastic diplegia, I find it interesting to learn about therapies and different things that affect people with other types of CP, because it's such a broad umbrella diagnosis. For sure.
Yeah, of course. Yeah.
I had another question for you, which is, other than what you've shared today, is there something that you would like parents and caregivers to know about your work?
I think that the thing that we want, I think kind of you spoke to it a little bit, just that we understand this sort of, big ordeal that you go through having, the kids that we're recruiting, a lot of them have been through the NICU. So to parents who have been through a NICU stay, we see you, we know that this has been a stressful time, and we want to support you. And whether or not that's through helping you find targeted interventions for CP, or helping you get a diagnosis of that, and providing support, not just for your child, but for the parents and caregivers that are, coping with this news of a diagnosis, that we want to use these things to help the parents get the support that they need as well. And that also for parents, like you said, who maybe have been through this NICU stay and they're wondering about the results of their test, that we see you too. And we're trying to, find the answers for you in the most efficient way possible. And that also that we appreciate parents who collect data for us if they're willing to use their smartphones, that they can play an active role in understanding more about their child's development and helping us to get that information too.
That's a really wonderful message, and I'm sure that parents and caregivers would appreciate that. One other question is there anything else you would like other clinicians to know about your research? We've talked a lot about it today, so if you've covered everything, that's okay, but if there's anything else that you want clinicians, or other people to know about the research that you've done and the research that you're undertaking newly, with this third study, we'd love for you to share that.
Yeah, I think that the other thing that is that, like I mentioned, I think that we are all at one point clinicians ourselves, or many of them still are. And we work with clinicians all the time when we teach this tool, and they are the best source of these questions because they're identifying the gaps in their understanding of the conditions or how the tool can best be used. So we're trying to partner with clinicians or use our own clinical expertise to drive our research questions to come up with meaningful studies that can actually solve or attempt to solve the questions that we may have as clinicians about what is the best time to test the kids, which tests to use, what to say to parents, and that also that, if clinicians have ideas or questions that they want to share, that they should partner with researchers or even do research themselves. It's when I teach the clinicians in the general movement class, they'll say, has anyone ever studied this? And I'll say, no, but that's a great idea for you. So,
Yeah.
or someone else, because, they're the generators of these questions. They know what's important. And, researchers are wanting to partner and share those ideas and develop things that help them to carry forth the research and implement it in a way that's feasible, because we don't want to design things that clinicians can't use. We
That
want
is
to,
an excellent point.
yeah,
Because there could be questions that a researcher absolutely wants to answer because they're curious or because it's interesting and unknown. But if the clinician can't use it, it's less useful, for lack of a better word. Um,
yeah.
so there are two kind of related questions in the Q&A. The first is, have you heard about getting targeted interventions like DMI therapy that requires an active response from a child in step-down NICU units? And just a comment that we know that early intervention is important, so shouldn't research be focused on this?
Can you say the second one again? I'm sorry.
It was sort of a follow-up to the first one, which was asking about DMI therapy requiring active response from a child in a NICU. And then, because we know that early intervention is important, shouldn't research be focused potentially, I think they're saying, on the DMI therapy in the NICU units? If you know
Yeah,
enough to speak to that.
I am not an expert on that. I feel like this is maybe dynamic movement, something that I'm not as familiar with. What I know about, so I guess I should say I don't know exactly, because I shouldn't speak to what I don't know. But what I do know is that we want things to be task specific and focused on what's important in their environment. So if we, children learn from the environment that they're in. And in the NICU, a lot of times, if they're still requiring a NICU stay, it's sometimes we have to work within the NICU physiologic stability of the infant, the medical stability that they face because they're still in an intensive care unit. So if it's things like, holding the baby and getting the baby to respond visually or to try to hold up their head. I mean, usually not always, but in the neonatal intensive care unit, they're still pretty young. So the intervention should be matched to their ability level and also what's the most sort of relevant for their everyday environment. So I don't know about the NICU, but once they go home, we learn from our environment that they should be things that they can sort of generalize to their everyday context, I think. And and that are meaningful to the family in the context of their everyday life so that they can get a lot of practice in those skills.
I think the last thing you said is applicable across the lifespan, that the therapies that children, adolescents, teens, young adults get should really be applicable to their daily lives and what is best for them and their families when they're still with their families, and if they're independent, what's best for them in their independence and whatever levels of interdependence that they have. And I think it's good to think about that framing to the side of all of the early interventions that are also important, just always keeping that in the back of your minds, that this is a person that is going to potentially go through life with a disability, and try to think of it in as productive a framing as possible, and thinking about their environments and what that does for them and what they need out of those environments is really helpful to start from the beginning. So
That's a super helpful perspective, Jocelyn. Thanks for sharing that with me, because I think that's a really valuable piece of information for us who are in the baby world.
you're welcome. I mean, my first memory of life is early intervention physical therapy, so do with that what you will. But no, my physical therapist helped get me where I am today. It's just been the early intervention is such a big part of life and an important part of life for someone who's suspected of or then diagnosed with a disability, that it's important to keep it in the context of that baby and young child as a whole human. So just something to keep in mind for the folks who are either live on this Zoom or watching this on YouTube down the line. We just have a few minutes left, so I want to thank you so much, Colleen, for everything tonight, and thank you to everyone who joined us. Make sure to keep an eye on your inbox for more about upcoming programs and ways to make a difference. Season 3 of our Changing with Possible podcast, which Colleen alluded to earlier, it starts this April, and we'll be covering the latest in cerebral palsy research, assistive technology, and more. So follow, listen, and learn how we're bringing science and technology to life to change what's possible and make accessibility accessible. Enjoy the rest of your night. Take care.